So, hello to you, to you out there who have joined. My name is Cary Dicken, and thank you for joining me tonight. I am one of the reproductive endocrinologists at RMA New York on Long Island. Reproductive endocrinologist is a fertility doctor. It means that I trained as an OBGYN, so I'm a board certified OBGYN, and then did a subspecialized training and am also board certified as a fertility specialist. So tonight, I want to talk a little bit about treatment options, and I'm going to focus namely on IUI and IVF. These are the two most common treatment options. I'm going to review the differences between these treatments and why a fertility doctor may recommend one over the other. I'm also going to go into detail about what you can expect when you go through each of these treatments. You know, how many shots are you really taking? How often are you coming into the office? And I'll discuss how you may feel physically. How are you going to feel emotionally? What might you go through? Sometimes the emotional can be the more challenging part. And of course, then we'll talk about the likelihood that each treatment could result in pregnancy. Please feel free to submit any questions in the Q&A box, and I'll kind of get to those at the end of the talk. Okay, so before we dive into IUI and IVF, let's just talk a little bit about reproduction. And these are a couple of interesting reproductive facts. Did you know that 1 in 6 couples struggle to get pregnant? So while many people are not talking about infertility or the difficulties that they have getting pregnant, it's a pretty common situation. You may also be surprised to learn that the likelihood of getting pregnant each month is really not that high. Even when you're young, you only have about a 20 or 25% chance of getting pregnant in each cycle that you're trying, and this actually drops to about 5% as you get to 40 and above. In the line graph that's on this slide, you can see that female fertility in red begins to decline around age 32. And this is not the case for men, meaning that age is definitely a bigger reproductive concern for women. The good news is that about 90% of infertility can be overcome with treatment. And advances specifically in IVF have drastically improved success rates. So far, there are over 8 million babies worldwide that have been born because of IVF. So who should see a fertility specialist? Anybody who meets criteria for the diagnosis of infertility should be seeing a fertility specialist. So the diagnosis is made for women under 35 when they've been having unprotected sex, does not need to be timed perfectly every month, unprotected sex for 1 year and have not gotten pregnant. That by definition is infertility, and you should be with a fertility specialist, at least initiating a workup. When women are a bit older and trying to get pregnant, we just don't want them to wait as long because of the impact of age on the eggs. So for women over 35, we say after 6 months of trying, 6 months of just unprotected intercourse, if you haven't gotten pregnant, it's probably a good idea to go on in for an evaluation with a fertility doctor. And then for women who have underlying conditions where we know it's going to be challenging to get pregnant, you shouldn't wait 6 or 12 months and say that you tried before you come in. You should come in right away when you're ready to conceive. So women, for example, who have irregular periods and aren't ovulating, or women who know that their tubes are blocked or have endometriosis, and we know that's going to make it challenging. Those are women that we want to see right away. Many people are often surprised to know that fertility doctors see patients that don't have infertility. We see couples that are having trouble holding on to a pregnancy, right? So recurrent miscarriages is something that we can help with. We can also use the technology that we have with IVF to be able to help couples that have known genetic diseases and are at risk for having babies with certain diseases that they don't want to pass along. We can help couples who or individuals who are looking to get pregnant using some sort of third party, whether it be donor egg, donor sperm, a gestational carrier. So there's a variety of patients that we do see. Now, I, as a fertility doctor, I'm always happy to see everybody, and I know you don't want to come and see me, but I want you to really think of a fertility doctor as someone who's going to be part of your team, trying to figure out what's going on and working with you to determine the best course of action for, any findings that we come across, or in figuring out your ultimate family plan. How can we help you to create the family that you want? Sorry about that. Okay, so in figuring out which treatment option is going to be right for an individual or a couple, we first start off by trying to learn a bit about you, right? So at the initial appointment with a fertility doctor, there's going to be a lot of conversation. We're going to ask you a lot of questions. Some of them do get pretty personal, and we want to learn about you and your partner. We want to know your history, your own personal history as it relates to your gynecologic history, your medical history, any surgeries that you've had. We want to know about your family, any history that somebody's gone into menopause early, anybody with recurrent miscarriages, or who's had babies that have had some sort of problem. We will do a physical exam as well as a pelvic sonogram to get a look at the pelvic anatomy to see if we can determine anything that may be affecting your ability to conceive. So essentially, we're trying to gather all of this information so that we can find any obvious reasons or even subtle clues for why you may be having trouble getting pregnant. At the initial visit with a fertility doctor, you probably will start some testing. Certainly the pelvic sonogram, right? When I see a patient for the first time, I do a sonogram and I can get a really good idea of a woman's ovarian reserve. So meaning the quantity of eggs that are in the ovaries that I may be able to work with treatment. I can't see every egg that's in the ovaries, but I can count these early follicles that are available in a given menstrual cycle. And it helps me gauge how that compares to other women of the same age and whether I think the ovaries might be aging a little faster, right? Do I see fewer eggs, or maybe I see a fantastic number of eggs? As little girls, we are born with our eggs. We don't make more eggs. And so getting an idea of the egg quantity is really important in determining, how a woman might respond to fertility medication, which treatment may work best, how aggressive do we want to be. There's also blood work that we do, and specifically as it relates to egg quantity, we want to check an AMH level. It gives us a really good idea and kind of confirms what we see on sonogram as it relates to egg quantity. Other tests that are important for us to do, doesn't happen at the first visit, but we're going to schedule a semen analysis. We need to know what's going on with the sperm. We need to know the amount of healthy sperm in the ejaculate. We also want to evaluate the cavity of the uterus. We want to know if those fallopian tubes are open. And then depending on a woman's history, there are some other blood tests that we may do. For a woman with PCOS, there are certain hormone levels I want to check. For somebody with recurrent miscarriage, there are different blood tests that I want to do to see if we can figure out what's going on. Now, the initial visit, right, is starting this process of trying to determine why a couple or a individual is having trouble getting pregnant. And so this pie chart, it's kind of a simplification, but couples usually fall into one of these categories. Either there's a female issue, a male issue, a combination of the two, or an unexplained situation. And the suspected cause for infertility is going to push us towards either IUI or IVF treatment. In addition, your doctor should consider a woman's age, obstetrical history, number of desired children, and your insurance coverage when recommending treatment. So even when there is no explanation for why a couple is having trouble getting pregnant, and this is seen in about 20% of couples, it basically is telling us that with the initial evaluation we didn't find an exact explanation. We don't know exactly why they're not getting pregnant, but something is making it more challenging. And because of that, we still are going to recommend treatment. Statistically, we know from the data that's out there that fertility treatment is still beneficial even when an explanation for infertility cannot be determined. Okay, so when it comes to fertility treatment, there are essentially two big categories, right? We have IUI treatment, which is intrauterine insemination, and we have IVF treatment, which is in vitro fertilization. So IUI and IVF are very different treatment options, both in how they are performed and their likelihood of resulting in a successful pregnancy. With IUI, and this is going to be the image on the left side of the slide, what we're doing is placing a highly concentrated volume of motile sperm into the uterine cavity around the time of ovulation. So one or both fallopian tubes must be patent, must be open in order for IUI treatment to have a chance to work. In addition, there must be a sufficient amount of motile sperm in the ejaculate for us to consider using this treatment. Whereas with IVF, so that's going to be the image on the right side of the slide, we're going to be stimulating eggs to grow in the ovaries, and we're going to remove those eggs so that we can fertilize them outside of the body. So IVF is bypassing the fallopian tubes, so we do not need them to be open or even present. In addition, IVF can utilize ICSI, which is a way of selecting good quality sperm to fertilize the egg, and that is going to help us overcome a male factor if there's not a sufficient amount of high quality sperm in the ejaculate. Okay, so let's focus on IUI to start, right? This is what some people consider artificial insemination. So naturally, right, with natural conception, sperm has to travel all the way up to the fallopian tubes to fertilize an egg. And out of all of, in a normal, you know, in a man who doesn't have an abnormality on semen analysis, we expect there to be millions of sperm in the ejaculate. But with intercourse, only about 5% of the sperm make it to the fallopian tubes. With IUI, we're going to get the high quality sperm, right? The really good swimming sperm. And we're going to concentrate that into a very small volume. And we're going to place that in the uterine cavity, making it much easier for more sperm to reach the eggs that are going to ovulate. Now, typically, women will use some sort of oral fertility medication to help them grow and ovulate more than one egg. They come in 2 or 3 times between the start of their period and ovulation to monitor how they respond to this medication. A single small injection is frequently administered to ensure the timing of ovulation and to determine when IUI will be done. An IUI itself is not terribly invasive. It basically feels like a pap smear. It should not be painful. It does not require any anesthesia. And afterwards, you can kind of get up and go on with your day as you normally would. So essentially, IUI treatment is increasing the odds of pregnancy by getting more eggs and more sperm closer together at the right time and hoping that a healthy embryo will be created and result in pregnancy. IUI treatment is often recommended for couples where there is a mild male factor infertility or in an unexplained infertility when women are under the age of 38. This is also a treatment option that is often used by women who are hoping to get pregnant with donor sperm. IUI cycles typically require less monitoring than IVF, so fewer office visits during the time of treatment. Like I mentioned before, they are not invasive and do not require any anesthesia, and they happen to be a fraction of the cost of IVF. Now, my patients are always surprised to learn that IUI treatment, even under the most ideal circumstances, IUI treatment does not give great odds of success. And age is going to play into the chances of getting pregnant. And as expected, as women get older, the chance of pregnancy is going to decline. For couples having trouble conceiving, IUI does give a better chance of success compared to trying naturally. So it's not that the treatment is not worthwhile. I would say we just don't want couples or women spending too much time with IUI treatment. Most fertility doctors recommend 3 IUI attempts, and if not pregnant at that point, at least having a conversation about moving on to IVF. Also, as women get older, it really is more efficient to just bypass or skip IUI treatment and go right to IVF. Essentially, as women get older, we don't have time to waste with a treatment that gives less than a 10% chance of pregnancy per treatment cycle. Okay. So that's the gist of IUI treatment. Moving on to IVF. So IVF, or in vitro fertilization, is a significantly more effective and successful fertility treatment option compared to IUI. The procedure can be done using a woman's own eggs or with egg donation from a younger woman. And there are several reasons why your doctor might choose IVF rather than IUI. So just looking at the list here, age, right? As women get older, we said we don't want to waste too much time with IUI treatment. So when women are over 38, it's actually more efficient to just go straight to IVF treatment. A woman who has tried IUI, has done several cycles and isn't getting pregnant, move on to IVF. If a woman has blocked or absent fallopian tubes, IUI is not going to work. We need IVF to bypass those fallopian tubes. If there is a severe male factor, meaning either a very low concentration of sperm or very low percentage of motile sperm, IUI is probably not going to be effective, and we want to utilize IVF so that we can help sperm fertilize the egg. Endometriosis is a gynecologic condition that's seen frequently in women who have trouble getting pregnant. It can affect a variety of aspects of infertility. And basically, the mantra with endometriosis is we just want to be aggressive sooner rather than later, because most women with endometriosis have trouble getting pregnant. So we don't want to spend too much time with IUI. We may want to go straight to IVF. DOR stands for a diminished ovarian reserve. So in that initial workup, if we see a lower egg quantity than we would expect, it may be a sign that the ovaries are aging faster than we anticipate. And again, same reason as endometriosis. We just want to be aggressive sooner rather than later. If there is a known uterine factor, some women are born without a uterus or for whatever reason have it surgically removed, or we know it's not functioning properly, well, then we need to create the embryos in the laboratory so that we can use those embryos in somebody else's uterus. That would be a gestational carrier. I mentioned earlier that some couples are at risk for specific genetic disorders or having a baby with a specific genetic disorder. So if we wanted to be able to create embryos to test those embryos for that genetic disease before a woman gets pregnant, it would require IVF. That's something called PGTM, testing for a specific monogenic disorder. When we see couples for recurrent pregnancy loss, the most common explanation is that they're getting pregnant with embryos that are abnormal, meaning they have an incorrect number of chromosomes. So if we use IVF, we can create embryos and test the chromosomes before a woman gets pregnant. And then finally, family planning or family balancing. I see patients who want a child of a specific gender because they want to balance their family. With IVF, we can create embryos and check the chromosomes, which includes the sex chromosomes. So that's the only way we can determine gender. Um, in addition, sometimes couples are starting to start their family when women are 35, 36, 37, and they may know we really want to have 2 or 3 kids. If we do IVF and create 35-year-old embryos, even when a woman comes back when she's older, let's say at 40, to use them, her odds of getting pregnant are based on the age she was when we extracted those eggs and created the embryos, meaning I can give a 40-year-old the odds of getting pregnant as if she was 35 again. So that's another good reason to think about IVF rather than IUI. So in terms of how IVF works, again, very, very different than IUI treatment. So IVF stands for in vitro fertilization. That means we're going to fertilize a woman's eggs outside of her body. The first step is for a woman to use injectable medications to get her eggs to grow. Most of the protocols that are used will require 2 to 3 shots daily. These are small injections, subcutaneous, meaning the needle just goes right under the skin, usually injected into the lower belly, and women or their partners are able to do this themselves. The use of injectable fertility medication comes with more frequent monitoring with your doctor so that we can watch how the body is responding, how the ovaries are responding. We want to see how many eggs are growing. We want to make sure that it's optimal. We want to make sure we can also figure out the best time to extract the eggs that have grown from the ovaries. Okay. On average, I'd estimate that women usually are taking these injections for about 10 days and probably come in about every other day during that time to be monitored before having the eggs extracted. Right? Most women are going to tolerate these medications pretty well. I would say most of my patients tell me that they're pleasantly surprised by how they feel, and I think the anticipation of what's going to happen with an IVF cycle is probably worse than what it truly is. Once the eggs start to grow, the ovaries are going to enlarge, and women sense this by getting a bit bloated, crampy. I would say, especially as we get close to doing an egg retrieval, they're going to get uncomfortable. And the more eggs that are growing, the more uncomfortable a woman may be. A woman should never be in pain. It is not normal to be in pain during IVF, but it is normal to feel your ovaries. Right? Walking around day to day, most women don't feel their ovaries, but as they enlarge from the eggs growing, you will feel them. To extract the eggs, the procedure that we do, we call it an egg retrieval. The procedure is done vaginally. So this is not surgery. Nobody is getting cut open anywhere. There are no scars on the body, but it's done vaginally while a woman is under anesthesia. It is not general anesthesia. It's typically just an IV sedation. A woman may only be under anesthesia for 15 or 20 minutes, so it's pretty quick, but obviously this is more invasive than doing an IUI. Once we have the eggs in the laboratory, they need to be fertilized with sperm a few hours later. So while there's more than one way for this to happen, most often what we use to fertilize eggs is a procedure called ICSI, ICSI. It's an acronym that stands for an intracytoplasmic sperm injection. This is basically a very fancy way of saying we are going to get that high quality sperm, right? We wash and prep the sperm, and we're going to select what looks like a normal appearing sperm and inject one normal appearing sperm into each egg that we got. Okay, now injecting the eggs into the sperm into the eggs is not going to guarantee that an egg fertilizes. Typically, we say about 80% fertilization is what we're hoping for with ICSI. So once an egg fertilizes, it is called an embryo. Okay. The embryos that get created through IVF are going to grow and develop in the laboratory for about 5 days before we can either consider transferring an embryo into the uterus in hopes of achieving pregnancy, or we can consider biopsying an embryo if we're planning to test it. And this really depends on, what a patient has decided with their doctor. Okay, so now the question everyone always wants to know is IVF going to work? You know, due to the constant evolution and progression of IVF technology, the success rates with this treatment have significantly risen over the past 3 to 4 decades. And you can see on the graph, you can clearly see this in the graph on the left, but it's still important to understand that the chance of having a baby from IVF is still very much dependent on the age of the woman who is going through the treatment cycle. So you can see in the bar graph on the right that for women who are under 35, they have very similar high rates of live birth per embryo transfer and per IVF cycle, but this is going to decline as women get older. So the likelihood of success with IVF still depends on the chance of being able to create a healthy embryo. And the likelihood of that happening typically comes from age and the impact on the eggs. So how do we know with the IVF treatment that we're actually creating healthy embryos? And I should say what I mean by healthy is chromosomally normal, meaning there are 23 pairs of chromosomes and there are no deletions or duplications. So by simply looking at an embryo under the microscope, we cannot tell which ones will have a chromosomal abnormality and which ones do not. There are grading systems in place for embryos, and that corresponds to the likelihood of them implanting and resulting in pregnancy, but the truth is it may not correspond perfectly with which ones are chromosomally normal. So thankfully now we have the technology to be able to screen embryos, and this technology is called PGTA, or pre-implantation genetic testing for aneuploidy. Aneuploidy just means an incorrect number of chromosomes. And this is something that can only be done with IVF. This is not an option with IUI. And you can see that over the past decade, the percentage of IVF cycles utilizing PGTA has increased significantly from about 5% to about 50%. So this is huge. This is something that we are commonly doing now with IVF cycles. So PGTA is going to require that we biopsy each embryo that develops normally. And the biopsy itself is then sent out to amplify the DNA and to be able to screen the number of chromosomes. And when that analysis suggests that the embryo has a correct number of chromosomes, that single embryo gives about a 60% chance of pregnancy and lowers the risk of miscarriage to about 10%. Now, if you look at the graph on the right, you'll see that when embryos are screened for chromosomal abnormalities, normal embryos for women of all ages give these similar high odds of success. So the challenge with age and IVF is not getting pregnant with a normal embryo, but actually creating a healthy embryo. So as women get older, even with IVF, there's going to be a lower percentage of healthy eggs, making a lower percentage of healthy or chromosomally normal embryos. So it's not uncommon with IVF treatment that it can take more than one treatment cycle to be able to find a healthy embryo. But once we do, we believe, based on our data, that the likelihood of getting pregnant from transferring that healthy embryo is not dependent on age. So what if You talk to your doctor about what's going on, you try IUI, you try IVF, it's not successful. I know the purpose of my talk was to talk about those two treatment options, but just so you know, there are treatment options that can overcome issues when IUI and IVF are not working. So before we can determine the best course of action, we have to think about the most likely explanation for why cycles fail. Do we think it's because of the egg quality, sperm quality, a combination of the two, or perhaps couples are creating gorgeous embryos, but they're having difficulty implanting in the uterus? After multiple failed attempts at IVF, and there's not one specific number, it really depends on the clinical situation, we're going to start thinking about this third-party reproductive option, meaning using eggs, sperm, embryo, uterus from a third party, meaning somebody outside the couple, to be able to achieve pregnancy. Third-party reproduction is a very personal choice. Some of my patients are happy to entertain it, others are not. So I do discuss it, but it's certainly not, everybody's cup of tea. Egg donation is when eggs from a younger woman are used to create embryos, and this is often the recommended option when egg quality is the biggest concern. Most often, poor egg quality is due to age. So when we use eggs from a younger woman, it essentially makes the likelihood of getting pregnant that of the age of the donor, who is typically in her 20s. Egg donation, along with the use of a gestational carrier, is often something that's used by gay male couples. Donor sperm is something that we would consider when there's a severe male factor, or for female same-sex couples, or a woman who wants to conceive on her own. And then women who cannot be pregnant safely, right? Maybe they have an underlying medical condition, or who have a missing or compromised uterus, may consider using a gestational carrier. So I know that's a little bit beyond, just comparing IUI and IVF, but those are other treatment options that we think about. So some take-home messages, and then I'm certainly happy to answer questions. Sorry. So infertility is common, right? We said 1 in 6 couples are going to experience some degree of infertility, and you should see a reproductive endocrinologist or a fertility doctor if you're having trouble conceiving, or if you have an underlying condition that is going to make it difficult to conceive. Please don't spend 6 to 12 months trying only to learn that you should have come in earlier, because we need to help you. Okay. An initial appointment with a fertility doctor will not be scary. It's a lot of talking, initial diagnostic testing, trying to figure out the root of what's going on. And then you and your doctor will work together as a team, taking the diagnostic information and your family planning goals and how your insurance covers this treatment, and figure out the best course of treatment for you. Okay. And thankfully, most couples are successful with their fertility treatment. I wish I could say it's everybody, it's certainly not, but the majority of couples are going to be successful, which is a really beautiful thing. Well, thank you for joining me. I'm going to do my best to see if there are questions without, hopefully without messing up the technology here. Gosh, bear with me for 1 second. I see there is one question. Is IUI the only option if over 45 with good ovarian reserve and no fertility issues aside from the age factor, and you don't want to use donor eggs? So that's a great question. I will tell you that it's probably dependent on the clinic and the doctor that you're seeing, right? So at RMA, we do not do IVF with a woman's own eggs once she turns 46. And the reason for that is because with all of the cycles, and this is including cycles at the Long Island facility as well as Manhattan, there just hasn't been any success once women are 46 and above. So that's our own cutoff, but I cannot say that every fertility clinic is going to have that age cutoff. Some might be older, some might be younger, so it really depends on the situation. But I will tell you that as women get into their 40s and certainly their mid and late 40s, the likelihood of there being good eggs that are going to result in healthy embryos is extremely low. And so the chance of success with IVF using your own eggs at that age is not going to be anywhere near where it would be with donor eggs. Any other questions? Oh, one more just popped up. First question, how does semen analysis work if you use a sperm bank? So that's, I want to make sure I'm understanding the question correctly, meaning like a sperm bank where you're purchasing sperm, or an outside facility where you're going to store your partner's sperm. I can tell you the way that semen analysis works if you're purchasing sperm from a sperm bank is that the semen analysis has already been done. And when you're purchasing sperm from a sperm bank, they're going to tell you in the vials that you buy how much motile sperm would be in the donor's vial. So again, depending on whether you're proceeding with IUI or IVF treatment, you might buy sperm that is washed or unwashed, or IUI ready versus IVF ready. So it really kind of depends on what you need. But getting sperm from a sperm bank means that semen analysis has already been done and that donor's been screened and everything was suitable for them to be a donor. Is there any sperm banks that RMA recommends or works with? We will work with any sperm bank that follows FDA regulations, right? So there are specific requirements for testing and quarantine when using donor sperm. That being said, I can tell you that some of the larger sperm banks out there, California Cryobank, Seattle Sperm Bank, Virginia Fairfax, I would say those I see very often. There are some more local, smaller sperm banks in New York. I think there's one called Zytex and one called Cryos. I believe they're in New York. But we don't have like one specific sperm bank that our patients use. Estimated cost for both procedure, excellent question. So I mentioned that IUI is a fraction of the cost of IVF, and that is definitely the case. Every clinic is a little different with how they, charge things. At RMA, I believe an IUI cycle is ballpark like $800 to $900 per cycle. The IVF cycle, not every IVF cycle costs exactly the same amount of money, but I would say depending on what's going into it and the cost of medication, it completely out of pocket could be $15,000 to $18,000, right? So clearly IUI is a fraction of the cost of IVF. If a round of treatment fails, how much time is needed between rounds? So that's another good question. So consecutive cycles can be done, meaning, if you do an IUI or an IVF cycle and it's not successful, you can be seen to start another treatment cycle with the next menstrual cycle, but it's going to be dependent on a couple of things. Number one is insurance and whether there needs to be an authorization that's obtained again and how long that's going to take, because sometimes they will need to see the outcome from the first cycle before they authorize another cycle. Secondly, whenever you use medications, whether they're the oral or the injectable fertility medications, to stimulate egg growth, there is a slightly higher chance that there could be residual cysts on the ovaries. And sometimes it's okay to still go forward if there's a small cyst, but if there are multiple cysts, if it's large, if it's producing hormones, we may want your body to have a rest for a cycle and then you start the following month. If you're doing IVF and already have frozen eggs, what's the timeline like, and do you still need to do injections? So if you already have eggs frozen that you're planning to use with an IVF cycle, you do not need to use injections The injections are going to be to stimulate egg growth. So the only reason to use the injections is if you want to extract maybe fresh eggs and use them in addition to the frozen that you already have stored. But if the plan is to just use frozen eggs, the frozen eggs are going to be thawed for fertilization based on the preparation of your uterus. And so that's usually a much easier procedure to do and really does not require many injections. Sometimes injections of progesterone leading up to the transfer of an embryo, but not injections like with IVF to get eggs to grow. There's another question here about how many cycles for IUI and IVF. I'm guessing that means how many cycles would I do for a patient for IUI and IVF? So with IUI treatment, the data suggests that most couples that will be successful with IUI treatment are probably going to be pregnant in one of the first 3 tries. So I usually like to say after 3 cycles, if my patient isn't pregnant, I want to at least have a conversation about, do we want to keep doing this or do we want to talk about IVF at this point? How many IVF cycles is difficult because that number is not going to be the same for everybody. For IVF, it really depends on what's happening. If a couple is not being, or a woman is not being successful with IVF treatment, is it because we just haven't gotten the right egg and the right embryo yet? Or is it because her ovaries are not responding to the medication? That will determine how often I'm going to recommend that they continue to try, right? If I'm giving medications to a woman and her ovaries are not responding, we'll try 2, maybe 3 times, but at that point, continuing on is probably not worthwhile. We're probably not going to see much of a change. But if it's a matter of, okay, well, we got eggs and we created embryos, but we just didn't find a healthy embryo, as long as a woman wants to keep going, I will. It depends, of course, on insurance and cost, but it also, at a certain point, and that number can be different for everybody, I may start to have conversations about that third-party reproduction. How many times are we going to keep doing an IVF cycle in hopes of getting a successful outcome if it's not, working after 4 or 5 plus cycles, it's at least worth a conversation, in my opinion, at that point to figure out if we want to keep doing what we're doing or move on to another option. But there's not, it's not kind of written in stone, like this is how many IUI cycles you can do and this is how many IVF cycles you can do. All right. Any other questions? Oh, I think we just got one more. Let me see if I can get to it. Oh, thank you. It's just thanking me for the talk. It's my pleasure to do this and hopefully to give you some accurate information that you can trust, because I know, myself included, I'm always Googling and reading things that, when it's not my specialty, I don't know what to trust. And so I know that's the same thing that a lot of my patients tell me about the infertility world. So happy to give some hopefully useful and accurate information. All right, well, if nobody else has questions, I think I'm going to end it here. Let me just make sure I hit everything. Oh, one more question. With IUI, is there any way to test embryos or the quality of the eggs if you're an older patient? No. With IUI, we are just getting eggs and sperm closer together. So we don't know anything about the quality of the eggs. We know sperm counts, right? So we will know how much motile sperm we're placing, but we won't know anything about the quality of the embryos or whether they even get created, right? With IUI, if a woman doesn't get pregnant, I don't know if the eggs didn't even fertilize or if a fertilized egg stopped developing, right? Fertilized egg is called an embryo if it stopped developing, or maybe, they made a healthy embryo, but it just didn't implant. There's so many steps along the way between an insemination and determining if a woman gets pregnant. There are many steps along the way where things can go wrong, and we just won't know anything about where on that kind of pathway that something went wrong. It's only with IVF where we're actually seeing the eggs under the microscope and seeing which ones fertilize and develop properly and see how the embryos are growing. And even then, the final step is testing the embryos to check the chromosomes. And that's only with IVF treatment. All right. Well, I hope everybody has a good evening. And thanks for joining me. Be well. Bye-bye.